everybody. This is Sarah DeSilvi. I'm the Director of Terminology for the Gravity Project. It's my honor to welcome you here today to the April 14th call. We're going to start on time, even though we're kind of rolling in. We have a lot to cover today, and we have a special presentation, so I am going to start in. Next slide, please. I want to thank you all again for joining the meeting. Just some business stuff that we always mention. Due to the large number of attendees, participants are muted upon entry. We ask that you remain muted to avoid background noise. All the calls are recorded. And as anyone who's attended the call knows, we work really hard to integrate questions and comments into the chat. From the chat into the conversation, just make sure you send any comments to everyone. Just as a courtesy, do try to comment in the chat on topics that are currently being presented. If there's side conversations to be had and connections to be made, we appreciate that you send each other emails and then you can talk offline so that we can continue the business of the meeting. And next slide, please. This is the Common Gravity Project Antitrust Practices slide. Next slide, please. This is again our every other week and constant invitation to formally join the Gravity Project. If you want to check if you've joined, you can check at the Confluence there as well. And then as always, the Confluence is a massive trust and vault of information regarding the Gravity Project past and current activities. Over the course of the talk today, there will be the links will be dropping into the chat so you can Thank you. So just remember, if you're going from WebEx, sometimes you have to click twice in order to get to the link. Next slide, please. A big, huge thank you to our project founders, grantors, and in-kind supports to date. Next slide. I do want to state, kind of a pressing need. So the Gravity Project's currently seeking additional sponsors for our 2022 operations. We do require sponsors for sustainability. It's an opportunity to be recognized contributor to our critical national work. If you have any interest in learning more about sponsoring opportunities, as is with everything the Gravity Project at EMIadvisors.net, email is a really great place to go, or you can visit the Confluence and there is a page on sponsorship. Next slide, please. This is our agenda for the day. We'll go through some announcements. We'll talk about the project schedule and overview. We'll go through the health literacy end-to-end review and update on health insurance coverage status and medical cost burden. We have a special presentation today in honor of Black Maternal Health Week. Our amazing community liaison, Asha Emanuel, is going to speak briefly on the intersection of gravity, social determinants of health data standards, and the use case of improving maternal health equity. Mark will give a policy update, Greg will give a tech update, and then we will close. Next slide, please. Announcements, next slide. Evelyn, are you on the call, friend? She might be. I'm gonna let me just see if she's on the call. I also can speak in here. So she is feeling a little sick today. So one of the first announcement is registering for the ONC Social Determinant of Health Information Exchange Learning Forum. They had their kickoff in March. We really want to make sure that everyone's contributing. There were lots of friendly voices in the last forum. We want to encourage you all to join the CDC's SDOH Public Use Case Work Group. The official kickoff of that is April 20th. Gabby, are you on the call? Do you want to speak to that? Are you with us, Gabby? Maybe she's coming in soon, but that's fine. So keep on going. We want to highlight again, specifically figuring out Black Maternal Health Week, the IAG information session for prioritizing data elements for maternal health use cases in USCDI on April 20th and 27th. All of this information is available further information is available on the Confluence. We wanted to highlight a request for proposals from our sister organization and kind of parent organization, Siren, Our colleagues at UCFF Siren are having are putting out proposals or seeking proposals for racial health equity and social care meeting in fall 2022. The due date for those proposals is April 22nd. And then we wanted to highlight, we do try to highlight any relevant granting opportunities. So we wanted to highlight the eHealth Exchange Innovation Grant, intent to apply due by April 29th. Again, all of these announcements and more information is available on the Confluence at the link. Next slide, please. All right, next slide. So this is our current 2022 roadmap. We were unable to have our EC meeting today because of we had some attendance. We didn't meet quorum, but we are actively placing our fall domains on the register. So if funding comes in, we will kick off our next set of domains in August. And so the next time you see this, I hope that you will see the domains for the fall dropped into those to be determined spots. We are planning, if you follow the line down, we are planning for that May Connect-a-thon. We are kicking off the pilot affinity work groups. We are finishing our domain work. So as has been the case for some time, every element of the Gravity project is in process, whether it be our terminology domain work, our technical work, or our pilot work. And we look forward to seeing you at the Connect-a-thon in May. Any questions on this slide? All right, next slide, please. And next slide. On to terminology, next slide. This is just an update. Next slide. This is going to be very familiar to folks. We just wanted to make sure that everyone got their comments in, as most are aware. We presented to the ICD-10 Coordination and Maintenance Committee in March, and the comments on the Gravity requested terms have to be submitted no later than May 9th. You directly email them to NCHS ICD-10CM@cdc.gov. There, as usual, there is a form letter provided on the Confluence, and you can always see the Gravity submission. The formal submission can be downloaded from the CDC, NCHS, ICD-10 Coordination and Maintenance Committee's webpage, and all of those links are available on the Confluence and soon to be in the chat. Any questions here? Hi, Lucy.
Hi, everybody. Are comments to ICD-10 public? Do they go on a website or not?
They actually do not, which is it's a deviation from normal process. So it's a little, there are the public, unless, Linda, am I incorrect? I'm calling out my amazing Linda.
I'm not actually sure about that. I don't remember seeing any location, but we can check and verify.
Yeah, it's not as formal as the public register, right? So I do not think so, but we will get back to you, Lucy.
Thank you.
Yes, of course.
Just
Excellent.
Point of information.
Yeah, exactly. Yeah. Any other questions on this slide? All right, next slide, please. And next slide, here we go into the work of the day, or some of the work of the day. Here we are in our schedule. So we are entering the end-to-end review process for health literacy. We're reviewing concepts and submitting concepts for medical cost burden. I want to note that we did update the term health insurance coverage status. After some comments from our last call, we found a definition that was sufficient to ground the use of that term as kind of a both reuse, but I do want to honor that that's a change. We will head into consensus voting on May 12th for health literacy. So do spend the time to go through the comments and review them. And then we will carry on with medical cost burden and health insurance coverage and close that out at the end of May. As always, the homework is to review the things that need to be reviewed and submit concepts. So the question to make a change to an ICD-10 code, who makes up the body that reviews the proposals? So that's a complex statement. So we submit anyone can submit a request for an ICD-10 code change. to the National Center for Healthcare Statistics ICD-10 Coordination and Maintenance Committee. They meet twice a year. And all this process, I think, is contained on the ICD-10 page on the Confluence. In order to get on the agenda, there is often some background work directly with the team from NCHS and ICD-10. The committee membership is the bodies who are on the committee. You can see who they are, yes. And that is publicly available on the CDC webpage. And then there's also a public meeting, and this is what we had in March, and it's to kind of happen again in September. And then there is public comment within the meeting, and then there's public comment, well, public insofar as submitted comments afterwards, and then there is internal review that is not public. So the process between the public meeting and the agreement on the release of the terms is the marrying of the public meeting and all of the comments that have happened from the public meeting going forward. I hope that is a sufficient answer. And I'm sorry, these were they were requested to me. So everything that happens in the chat, I read out loud because I can't tell what's to me and what's not. So someone was asking about the IC10 CM process, and I just read it out loud because I can't tell everyone from me when I'm talking. Any other questions? All right. Okay, next slide, please. All right, so here we are. We've moved along our process. We're into the review stage with health literacy. Next slide. And next slide. So there really are, as there should be, very few changes in the slides you'll see going forward. While I was presenting and starting off, I realized I neglected to drop in our what do we do an end-to-end review slide, which I would have to pull back from the archives from the fall. I'm going to just say this out loud, and then we'll include it as part of our email to the collective next week. So the end-to-end review process should be at a point where we have collectively identified the things that we feel like need to be said for a domain. And we shift from submission to review. So the questions we ask ourselves are there things missing? Are there things that should not be in there that are extraneous? And are there things that need to be corrected? So those three questions: are there things missing? Are there things that are extra or duplicitous and we don't need them? Or are there things that need to be corrected and changed? And we do this process collectively with intention by reviewing the master lists, which can be downloaded from the Confluence. And we focus on any changes that might be coming up in our public call. But this is really the end of intent submission and the beginning of just ruminating on whether it is correct and good enough. So that's what we'll be doing over the course of the next slides. And that's why there's very little new items, because by now you are all well familiar with the health literacy elements. So the health literacy definition for personal health literacy has not changed. Next slide, please. It's thundering in Vermont, so if you hear thunder, that is why. The organizational health literacy, although we initially thought we wouldn't be within scope, we defined that it was absolutely necessary to include it, and so we developed a process for that, and here's the definition here. It comes from Healthy People 2030. Next slide, please. This is a comprehensive list of the screening tools that you will find in the master. So over the last few weeks, we've been talking about new screening tools, but this is really the sum of them all. So there are brief screening tools, one-item screening tools, organizational screening tools, personal screening tools, and gleaned from the Boston University Health Literacy Toolkit, gleaned from our colleagues at AHRQ. And so this is the summary list as it stands so far. And really, we are careful to say that we aim for kind of a sufficient to meet the needs of the ecosystem at this time. There are some screening tools that are best in class from a research purposes that we do not include here because they're not really practical at this time for clinical implementation. But this is the list as they stand, and you can find all the question and answers on the master list if you download it. Next slide, please. Yes, hi.
I'm not otherwise familiar with this list. It seems to me amazing that there are screening tools from what must be so many sources, probably independent of each other. And so I'm wondering if each of these tools adds value to the conversation, so one needs to be familiar with all of them? Or are there one or two that someone not familiar could look at and generally come to appreciate all the work that's gone into this?
That's a good question. One of the things that we try to do within the Gravity Project, I'm loath to hold up one over the other. I can say the short assessment of health literacy, both English and Spanish, are the AHRQ's focus and their health literacy toolkit. I also can say that some of these tools are already implemented clinically, such as the brief health literacy screening tool, which is why it's already in LOINC. I don't necessarily want to point to like one being like the favorite child, but I would say if you were trying to orient yourself, the short assessment of health literacy, the brief health literacy screening tool, and then from an organizational health literacy perspective, the really critical medical expenditure panel survey, MEPS health literacy questions. So those are like, if you really wanted to just get a sense of the kinds of questions we're asking and how they can lead to assessments of health literacy, that's where I would start.
Thank you.
Yeah. Any other questions? And you can see that's why we starred the MEPS one, because it really is the gold standard for the organizational health literacy, which we know is so critical. All right. And you can, again, find all of these in the master list, every single question. It can be a little bit redundant to look at them because they're all queued and ready for LOINC submission. So everything, but it is all in there, and you can filter by tool if you need to.
So are they links? If we go to the Confluence page and find all of this, are they links, or does one have to figure out what the link is independently?
There are references, but we also have on the Confluence, we will be uploading and should have references for each of the different screeners.
Thank you.
It's kind of a, you're always really good at cross-checking process. So we'll make sure that we work like the Dickens in the background to get all this ready. So we'll make sure the front of house and the back of house are all set for you.
I know you do. Thanks.
All right. Okay, any other questions? Wonderful. And again, the goal is to meet people where they are. And if a question is standardized and disseminated in the ecosystem, it meets the Gravity Project criteria for moving it forward into LOINC, right? And these all are kind of best in class in their own way. All right, next slide, please. This is where we landed with diagnoses. We're going to sit here for a few minutes. So we have that nothing too much is new here. When we were last together, we presented our approach to defining organizational health literacy at the person level, but we're really pinpointing because we know we have to address organizational health literacy. It's difficult to attach those kinds of concepts to people, so to the person. So this is our solution, and it was well received by the community and by our colleagues in the ecosystem. The one thing we wanted to add, and this is actually a nod to our dear friend Lucy, who raised this. She's always good at finding things like this. So we had requires translation services, requires interpretation services, requires digital education, and requires plain language interventions. And again, all of these have definitions and references. So when we say plain language, there's a government definition and a hyperlink, just so, because we need those for you, and we also need them when we go to build the terms into SNOMED CT. And we added requires culturally responsive care to support health literacy from the cultural responsive care literature in the at the federal level. So that is the only new addition on this slide. Any other questions? And this is really supporting the fact that health literacy is comprehensive. It's partly about language and communication, but it's also not just about language and communication. And so we needed to represent the complexity of meeting people in their cultural home, in order to support health literacy from an organizational level.
Hey, Sarah, are we on the SNOMED CT codes? Is the plan to submit them as findings?
So these would be, these are all be findings. Yeah. So our diagnoses are all findings.
Yeah, so if the bottom ones focus on the organization level, most of the findings in SNOMED are person level. So how are we going to request like a new hierarchy under findings that focuses on organizations, or how in SNOMED are we going to clarify which is which?
So this is why the solution works, is because even though it identifies the system needs to do something, it attaches to the person. So it doesn't require any new structure within SNOMED. It says that it basically says that it is assessment of the individual that talks about, and there's similar codes within SNOMED CT that talk about what the system needs to do to meet the person, but it is attached to the person themselves.
Okay, great, thank you.
Does that make sense? And it took a lot, I have to tell you, Sindalyn, it took a lot to figure out how to do this within the constraints of SNOMED because of just that reason. But we, based on precedent within SNOMED, we feel like this will work.
Thanks.
Yeah. Thanks
So
for the smart question.
So quick question on the plain language interventions.
Mhm.
I'm not familiar with that term or what it means, but is it meant to point back to the organization in saying that they have not broken down the concepts so that non-practitioners could understand, if you know what I mean?
I do. Yep, that's exactly correct. And if we want to, I can try, or maybe one of the team can try to pull in the definition for plain language that we have from the, it's a federal definition, which is really just simplifying things, but it's not actually about reading level. So it's really careful to state this is not 6th grade reading level. It's really like decreasing jargon, right? And so and meeting people where they are. So we can try we can try and drop that definition into the chat.
Neat, that's fine.
Sarah, is digital education, is that defined somewhere? Is that platform agnostic? So you say to the patient, do you have a computer? Does your child have a computer? Do you have a cell phone? How is digital education supposed to work?
Well, digital education and digital access are different concepts.
Yes.
So this is really just the education from a digital literacy perspective, and this is the way there's 2 different ways we're working on digital literacy. Knowing that it's important, knowing that we really can't address health literacy without speaking to digital literacy, we do have digital literacy and digital literacy programs defined from our education domain, our less than a high school education domain, because supporting digital literacy was a critical intervention from that standpoint. And it would be within the scope, within the setting and the domain of the system. So if it's like, if you have, you know, if you're just really trying to teach a person how to access their portal, right? It would be specifically for the system that they're working within. But digital literacy is, first of all, access is different than being able to use the tools that are there. This is specifically focusing on digital literacy, and it would be, it really can't be agnostic because it has to be like, how do I help you access the information within your own health record? Thank you, Hamali. So Hamali just dropped the definition for plain language into the chat. And then Mark, so this is actually, it's not really a finding about the org or the doctor. It's like, but that's not, it's more that it's a way to highlight the things the system needs to do to meet the person, right? And as opposed to highlighting the deficiencies of the person. So we took the spirit of organizational health literacy, which is, what do I have to do to meet you? How well am I meeting you, right? And created finding terms that could highlight that that work needs to be done. So it is, in order to meet you, I need to offer translation services. In order to meet you, I need to revise what I'm saying to you within plain language. Mark, can you, a service any org must provide to serve the person. Can you unmute so I can understand what you mean?
Yeah, I'm trying to translate what you're saying. It sounds like it is about the person. It's about what services the person needs an organization to provide in order to be well met.
Exactly, right? So it's not, this is what yeah, exactly. So it's a way to highlight what the system needs to do to meet the person. So, which is the only way we can do it right now because of the constraints of SNOMED that Cinderlyn brought up. And ICD-10 CM is the same way.
I'll just flag that maybe the confusion in this conversation, or at least for me, is in calling it organizational health literacy. It leads one to initially think that it's about the organization. There may be some sort of a label that works better on reflection. Thank you.
And so the cloud, it's really a way to, this is what the cloud statement is intended to state. It's a way to represent organizational responsibilities at the person level. So it's the only way we can address organizational responsibilities at the person level, is to frame things like this. Yeah, and maybe that, so 2 weeks ago, we did talk about our pivot about how to address the sticky wicket of organizational health literacy, because we couldn't do it. We don't really have a process for assessing systems except for within, things like, the CAPS survey and things like that, which happen not directly at the point of care, but like after the care in satisfaction surveys. So our pivot was to really define the things the system needs to do, but in a way that we could attach to the person. And then we have, are there any, so Teresa is adding, everything that happens now, so Teresa's offering, is this something you feel like is missing? If you feel like something's missing, requires assistive technology to support health literacy, we would love it if you did it in the formal way, which is email it to gravityproject@emiadvisors.net, because this is that process of end-to-end review. So if you can just send an email, I think we're missing this, that would be helpful. Rachel is saying, shouldn't plain language in medicine be the standard of care, not intervention? I agree. I really agree. But highlighting the gap, is important, right? So if that is the missing link, that is the missing link. And I can say there's many things that we do in medicine that interventions that we do in medicine that should be best practice, but we definitely need to highlight when we're not doing it and we need to do better. Oh yeah, okay, yes. Lucy's talking about, I distributed a draft of digital education for organization promoting consumer participation, HIT. It exhausted me. It is, yes. Lucy, that's a good comment. So anything else here? So we have this CT diagnosis of difficulty demonstrating health literacy. We have the ICD-10 comments, and then the reason why problem with health literacy is bolded is it's live in ICD-11, but that means it's not here in the US right now. So we've been building it new within the US ICD-10. And then we have those ways of representing the organizational responsibilities of the person with our required statements.
Sarah, will we be submitting corresponding procedures related to the organizational focused problems?
Absolutely. There are corresponding procedures.
Great.
Thank you, Cinderlyn. Any other questions? And if there's missing ones, Cinderlyn, in your review, again, just from the cross-checking, that's what we collectively need to do in this process of end-to-end review, is just make sure we have all of those bits.
So help me out, Sarah, for the goals and interventions. We haven't reviewed those yet for health literacy. Is that correct? Because I'm thinking about, for some of these, the goals are not going to be, are they going to, how are you going to put them on the person when it's, you're pointing back to the organization and saying the organization needs to supply?
Can you repeat the question?
Yep. So for, there's also, these are diagnosis codes. We have yet to go, we have yet to go over goals and interventions for health literacy.
Either on the goals and interventions are on the next slide.
Okay, I'll wait.
But I want to make sure that I'm understanding. I may not be understanding you want to connect these to the goal statements. Is that what you're saying?
Yep, I'll wait.
Okay,
Thanks.
next slide, please. All right. So if there's subtlety that you feel like needs to be represented in the goal statements here, we would love it. So this is what the way we've taken so far is able to demonstrate health literacy is already in SNOMED CT, which is why it's bold. We didn't feel like that really addressed the complexity of what we know health literacy means, which is not just understanding, but applying. So we do have that able to understand and apply health information. And then in order to represent, again, when it's really an organizational responsibility that the person to meet the person, we are working through this and have been working through this over the course of the last month, really, which is has access to health information that's able to be understood and applied, right? And we're working through phrasing, but this would state that basically the system has met the person, right? So the person has access to information, whether it be it's in their hand or it's electronic, and they can access it and they can understand it and they can apply it. We had use, yes, we had use as one of the if you look on the master, you can see that both use and apply are there. We got some pushback from use last time, so we switched it to applied. Suzanne,
What's the difference? Why did you get pushback on use?
well, we had consume and use, and we were going back and forth between them, and then we decided that applying your education, and then we tried around applied as well, and people have feelings regarding all of them, so we just need to figure out what term is best.
So what does apply mean that use doesn't? Or connote or imply, or why
I don't know if I
apply?
can answer that question. It was just a thought from the community that this might be a better statement. So if we feel like use is better, that is fine. Whatever term we decide is absolutely sufficient. And you can see that's why it's like in italics, working through phrasing. If we feel collectively that understood and used is better, then that's absolutely wonderful. We just went back and forth. And if you look at the master again, you can see that both are there.
Okay, I would just put in a plug for use, because usability is a highly prevalent and presumably well understood concept within HIT. You don't just want to design things, you want them to be used by people. So that's why I think that use is plainer language than apply. I'm not sure, maybe other people on the call could explain why apply is a better word here. You want people to use what we do in their workflows, in their lives, in their families. Why is apply a better idea here?
And maybe it's not a better idea. So I think it's, yeah. And if we feel, oh, here we go.
Yeah, here we go.
And I think, Sarah, we're combining the patient's ability here with what they have access to, and perhaps just has access to useful, understandable health information is what this term is about. The ability, what they're able to do with it is the other two.
Yeah, so maybe we can simplify things for ourselves for just taking, Monique, you're always really good at saying that. So maybe we can save ourselves by keeping the application within the able to understand and apply health information, and limiting this one to the organizational level at the person bit, which is that the organization has done its part, because you're correct in that we tried to keep the same core elements of health literacy through both of these concepts. But if we're really trying, and Suzanne, I want to make sure that you feel like this represents what you were saying on the previous slide. But if we really are trying to simply represent the system has done its job, then maybe we don't need to use the applied here, and that could be represented in the other concept. I actually feel like that makes some sense. So again, if anyone has feelings regarding this, send an email, because that's how we do our formal review process. Yeah, we do use apply, correct? Like we do use apply in the personal one above. Any other thoughts before we move on? And Suzanne, did this answer your question? I want to make sure.
Yes, it did. I was wondering how we would have goals that pointed to the organization instead of the person.
Okay, and then this one that has access was the attempt to do that, and that feels sufficient.
Yeah, I think we're working on it. It's good.
Okay, lovely. From previous slides, seems like intervention should be focused on organization system. What they. Yes, so Rita, if this is where it's difficult to do interventions. Again, we weren't even going to address organizational health literacy because we really are working on person levels in our initial domains, but we so far have tried to represent organizational responsibilities at person levels. Intervening on the organization is something we have talked about in previous meetings as being required, because akin to what we say in all of our meetings, like the real solutions are structural changes, intervening in communities, intervening in policies, intervening in systems. For right now, we're doing our best to represent that responsibility and things I can do with this person in front of me. And in the future, we know, as we address some of our community domains and community and system level needs, we will have to think about how to intervene in the organization as well. Okay. Okay. Hi, Denise. Okay, lovely. Okay, next slide. Are we good with this one? Okay. The only new thing on the interventions slide is the referral to interpreter, because whenever there is a program, we always ask ourselves where there's a person. Interpreter, we are usually bound when it comes to professions to only building within SNOMED referrals to professions that are within the National Uniform Claims Committee and UCC provider taxonomy. So the interpreter is there. Community health worker was there too. So this is why we're referring to interpreter within here as a new intervention. Okay. Does that make sense? Like we can't, we are trying to get some missing professions built into NUCC, but for right now we're bound by that. All right, next slide, please.
Sarah, this question may seem really off the wall or from Mars. Go back to the previous slide.
Okay.
If somebody comes in, let's say a really elderly person who speaks no English, and they are accompanied by a family member who speaks some English, but or Spanish or whatever the going language is in that setting. I don't mean to insist that it's always going, that the communication is always in English. But what I'm wondering is it ridiculous to think of health literacy interventions for a family member rather than for a patient? And do any of these do that?
Any of these could be used by a caregiver, certainly. Right?
Okay.
You would, the way it would be manifested depends on the situation, right? So for I'm family medicine, I refer on behalf of caregivers all the time. I intervene on, the parent, the guardian ad litem,
Mhm.
and then we do this,
So for recording, could one imagine, I don't know, the Z code dot XXX1, meaning the patient, the intervention is for the patient, and then Z code dot XXX2, the intervention is for a family member. Does that matter to anybody? Would that be of clinical significance? Maybe this doesn't matter.
well, it matters a little bit. It makes me think of the ICD-10 conversations we're having with the AAP now regarding, non-compliance. ICD is not really the place for that kind of differentiation that you're speaking of, but we do note, it wouldn't be an ICD. The one place where we're working on it with ICD is specifically regarding non-compliance, because we don't want the non-compliant, which is a horrible word, I understand. But the AAP is working to create caregiver non-adherence codes that separate responsibility from the child of reference.
Yeah.
But there is, but that caregiver could be applied in any situation. But again, ICD is not exactly the place where the specific information you're talking about would be done. But we do have the capacity to do referrals on the behalf of a caregiver within our model.
Thank you.
Susan's asking regarding, okay, so we were able to do a referral to community health worker because community health worker is a specific provider type within the NUCC, National Uniform Claims Commission committee. What's that last C? I don't know. They're in there within the taxonomy. So SNOMED was really comfortable with building that term. Referral to interpreter. Interpreter is also in the NUC taxonomy, so that also will be no problem. We are bound, SNOMED really asked us to cross-check and see whether the rules we're referring to are referenced in the ecosystem prior to doing referrals to them. But this doesn't exist right now. So, all right, next slide. Are we good? Because this was what a review is for, and I'm very grateful for the time we spent. Next slide. What I want to do is I want to honor the fact that we have a lot more to do, and we have time to review the updates in medical cost burden and health insurance coverage status, because we're not in end-to-end review with them, and we have until the end of May. So I'm going to give one quick update, and I think I'd like to pivot to the next items of the meeting, if that's possible. Does everyone agree that it's okay to pause? Because I want to make sure that we give Asha time and we also give Mark time and we give Greg time, and I don't want to take up too much of the meeting. Does that seem like a fair thing? I mean, does anyone have any objections? Understanding that everything where I would have been presenting on medical cost burden and health insurance coverage status can be found on the updated masters, and we will review it in 2 weeks, and there's no rush. Sorry, you think your brain hurts, Denise? That sounds good. The only thing I want to state is that this conversation within health literacy has really raised the criticality of addressing digital health equity. We had postponed, we had imagined doing that in like, a year and a half's time, but part of what we were asking, our committee structure is if we can elevate that and begin that in the fall in order to address both access and literacy swiftly, because it's been a constant thread through all of our domains so far. And it's very, very critical, of course, right now with the effect of the pandemic. So I just want to state that we have intention and focus on trying to address digital equity, which would include both access and literacy in short order. So once that gets approved, we will be working on that, and that is the most important. We do try to hold ourselves accountable to these kinds of things. Any other questions? And then maybe we can pivot to Asha, then Mark, and then Greg. Okay, next slide, please. Thanks, friends. Okay, again, one final statement. We're going to bump through these slides. You can fast forward all the way to Asha. As we're doing that, there's not many changes here. As we're doing this, I just want to state, remember everything that you feel, you're going to review those masters. You're going to send emails to gravityproject@emiadvisors.net about things that need to be removed, things that need to be added, and things that needs to be changed. Thank you so much. And now it's my honor to focus a little bit on a very important topic and center the voice of our amazing Asha Emanuel, honoring Black Maternal Health Week. And Asha, are you with us, friend?
I am. Thank you, Sarah.
Thank you so much. It just seemed very, very honored to have you speak today. And you were specifically focusing on how Gravity Project SUH data meets the maternal health equity use case. Take it away, friend.
There you go. Thank you so much, and good afternoon, everyone. I am a community health nurse specialist who is passionate about advancing maternal health equity in my community and beyond. And happy Black Maternal Health Week, everyone. So this year marks the 5th anniversary of the Black Maternal Health Week campaign. It was founded and led by the Black Mamas Matter Alliance. And Black Maternal Health Week is a week of awareness, activism, and community building intended to deepen the national conversation really about Black maternal health in the United States and to amplify community-driven policy, research, and care solutions. So as you all may or may not know, we are in the midst of a maternal health crisis in the richest nation on earth, and the trends are worsening. A woman giving birth today is 50% more likely to die of a childbirth-related cause than her own mother. And Black mamas are bearing the brunt of that crisis by being 3 to 4 times more likely to die than their white counterparts. And that's regardless of income and education level. In fact, a Black woman with a graduate degree is more likely to die than a white woman with less than a high school education. So we know part of the problem is bias, racism, and discrimination. And I can tell you, I've been a perinatal nurse and an OB case manager since 1996. I've experienced personally bias and discrimination as a Black nurse. And I've also witnessed countless instances of bias and discrimination for my Black patients as well. So we want to get really to the underlying drivers of maternal health inequity and talk about really the transformational impact of applying the Gravity standards to the maternal health population. Because I really believe that it will lead to better care, lower cost over time, and increased equity. Next slide, please. So I wanted to just level set, lift up the organization that I work for, full-time on a regular basis, the Center for Black Women's Wellness, which is a premier community-based organization based in Atlanta, Georgia. We have a 30-year history of serving our community, and our mission really is about empowering women to become whole, healed, and well. And our programming falls into three main buckets that include maternal and child health, wellness, and women's health. We do direct service in our safety net clinic, and economic health. And we see these to the keys to wellness. Last year, we served over 3,000 people, and about 95% of our population are Black women who live under the poverty level. I have the pleasure of serving as the Maternal Health Equity Program Manager, where our goal is to build a more responsive and respectful system of care through really three main areas of focus. Community-based participatory research. We are serious about amplifying the voices of Black mamas into the continuous quality improvement process. Policy and advocacy training to increase civic engagement and elevate community voices to decision makers. And of course, the AIM CCI effort, which I will talk more about later, but it is a community-oriented approach to standardize perinatal care and care services. Next slide, please. So I always like to level set with the statistics because really it is, it's stunning. I serve also on the Maternal Mortality Review Committee for the state of Georgia. And this was the latest fact sheet that was put out by the Georgia Department of Public Health. And this is for cases that we reviewed between 2015 and 2017. And the three things that I really want to elevate here are the fact that the majority, 87% of the pregnancy-related deaths that we reviewed were preventable. The other thing is the timing of the deaths. About 19% of those deaths occurred during pregnancy, and the balance occurred in the postpartum period. And then the last thing I really want to lift up is the disparity. Black women are 2.3 times more likely to die from pregnancy-related causes than white women. So the three takeaways: preventability, the timing, and the disparity. Next slide, please. So I just wanted to lift up one more compelling data statistics about the maternal health crisis in our country. This is the maternal mortality rate in the United States compared with the maternal mortality rate in other countries. And what you can see here again is that in the richest nation on earth, moms are dying at the highest rate in the developed world, and the rates are rising. So currently about 2 women die in childbirth-related deaths every day. That's about 700 souls, 700 communities impacted. And about 50,000 women each year suffer severe complications or life-threatening injuries. But what I want to lift up is that in my state, in my home state, the maternal mortality rate is on par with that of Syria, that has been in a civil war for the last 10 years. Next slide, please. So I wanted to really hone in on how SDOH, factors of health-related social needs, connect to health equity. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. And the social determinants of health, such as poverty, unequal access to healthcare, and housing instability, all contribute to health inequalities. And in order to achieve health equity, we have to eliminate health disparities and address the social determinants of health. And the path to achieving health equity really goes through social and economic factors listed here. So discrimination and minority stressors, there's food security and access to healthy foods, stable income and job security, environmental quality, neighborhood conditions, quality and affordable health care, educational opportunities, and of course, housing. So this is a really good illustration of multi-sector influences on health that really will require cross-sector collaboration in order to really address the social determinants of health. Next slide, please. So I wanted to talk to you about the Alliance for Innovation on Maternal Health Community Care Initiative, or short, AIM-CCI. And what this is a grantee from the National Healthy Start Association with a 5-year cooperative agreement from HRSA, with the goal being to address preventable. They're preventable. Remember, 87% of the deaths that occurred in my state were preventable. To address preventable maternal mortality and severe maternal morbidity among pregnant and postpartum women outside of the hospital and birthing facility setting. And this is all really about advancing community clinical integration by connecting and coordinating and collaborating centered around the person, the birthing person. So it's about achieving whole person care. There are 6 pilot sites around the country. And the role of the pilot site is to complete a test of feasibility on community-oriented postpartum interventions, and also to convene a local maternity safety work group to guide program activities, to implement the bundle elements, the interventions with an equity lens. And the equity framework is used really to inculcate equity into the continuous quality improvement journey, to discover and address the systemic, structural, and racial inequities that are the root cause of negative maternal health outcomes for Black women. And as I noted before, higher income and education levels are not protective factors for Black mothers. Next slide, please. So here I wanted to highlight the ways that the gravity standards could be useful to the maternal health population by also lifting up what are the AIM-CCI interventions themselves. So here we have to document and track SDOH-related interventions to completion. And the goal here is to ensure a closed loop referral process for non-clinical health-related social needs. As we have already noted, the driving force behind maternal health disparities are unmet health-related social needs. And the AIM-CCI intervention that aligns with this is this. It says to implement systemic processes to assist women and birthing persons in completing timely referral and follow-up for all identified medical, behavioral health, reproductive health, and social determinants by working collaboratively with community partners. So again, this is about achieving holistic care. And then the other AIM-CCI intervention is about implementing communication pathways between inpatient, outpatient, and community-based providers in order to facilitate and ensure continuity of care. And what this will do is it will enhance how essential health-related social needs are identified in community. It will also ensure residents are connected to vital resources that meet basic need with confidentiality and safety protocols. And finally, it will foster partnerships across the service spectrum to enhance access to services and build that cross-sector partnership. Next slide, please. The other use case is about gathering and aggregating SDOH data for uses beyond the point of care. So health is affected by multi-sector influences. We've already talked about what those are. And the goal here is to identify and reduce birth disparities by using SDOH data to detect inequities across all of those systems. And the 2 AIM-CCI goals, or interventions rather, that I want to lift up are to assess systems for unequal treatment and its impact, and to stratify health outcomes by race and ethnicity, and connect maternal health outcomes to social SDOH data. So we really have a good grasp on how those specific SDOHs or unmet health-related needs are impacting maternal health outcomes. But what this will do, it will promote community awareness, it will help build population health accountability, and it will also help mitigate those social and environmental risks, which account for up to 80% of a health outcome. Next slide, please. And then the last use case that I want to document has to do with documenting chronic stress or weathering assessment for Black birthing people. Last night, as part of a Black Maternal Health Week event, we had a short film screening called Toxic. And what this film highlighted was how racism and other toxic stressors impact birth outcomes. And this concept is called weathering. And the goal here is to predict and intervene in preterm birth risk factors for Black birthing people who are 50% more likely than women of other races to experience preterm births. And here I want to highlight Geronimus, who first coined the term weathering in 1992. And this is how he defines it. Black people experience early health deterioration as a consequence of the cumulative impact of repeated experiences with social and economic adversity and political marginalization. And what this does is it causes premature aging. So what we're advocating for is a future domain to assess for minority stress. And how that aligns with the AIM-CCI interventions is this. The intervention says we want to develop and implement a risk strategy, a risk assessment strategy inclusive of stress and its connections to birthing persons' experiences of racism and sexism. And there are three scales that I just want to lift up that we can consider. And that's the Jackson, Hogue, Phillips Contextualized Stress Measure. This is a race and gender specific stress measure for Black women for use in the maternal healthcare setting as a screening tool to predict preterm births. There's also the PREM-OB scale, which measures obstetric racism. And of course, there are the ACEs. But we are looking forward to future domain work that would include minority stress and strain as a social determinant of health. And let's see, Patika. Yes, the film is not available elsewhere for viewing. But if you go to our website, I do think that we are going at cbww.org. We are going to post. We did buy the rights to rent that film for up to a year, so we're going to figure out how to share it on our website. That concludes my presentation on that. Sarah, thank you.
Asha, thank you. I'm every day I'm grateful to work with Asha. I am grateful for her wisdom and the focus of her work and the importance of her work always, and especially today and on this week. And thank you so much for being willing when I wrote you to center in this work on this week. And I'm just so grateful for you. It's a little emotional. I do want to state, so part of the reason for asking Asha to come forward was that gravity gets asked often to solve all the problems in the universe. We recognize that as a general concern because of the requirement of inpatient and outpatient coordination, addressing the predicament and the inequities of maternal health outcomes is largely going to be outside of gravity's scope. And so I was just grateful for Asha to highlight these areas of alignment and alliance, right? So standardizing SDOH data collection, being able to aggregate it and analyze inequities, and then looking forward ahead to our focus on minority strain, discrimination, and bias and stress. So Asha, thank you.
My pleasure. Thank you.
All right. Wonderful. Okay, so now, I'm sorry, I'm still all emotional, so we have to carry on. So next slide, please. Those slides, every time you present them, Asha, they just it just, oh my God, it just renders my heart open. Okay, Mark, passing the mic to you.
But Sarah, do we want to go back and just see if anybody has questions? It was an amazing
Oh yeah, I know.
presentation
So
of
I'm
work,
too
but
emotional to do
people
that.
it may have generated a lot of good thoughts.
Sure.
I think if there are no thoughts, just know that Asha is part of our team, luckily.
I have a question or a statement. This is Janice. I really
Hey,
appreciate it.
Janice.
Hi, I'm a patient partner and I just really appreciated this. And I think what you mentioned is, it's just shocking about, like, I don't know how to say it, but it reminded me of the political determinants of health, right? Daniel Dawes' book. Have you read it?
I have, yes.
Yeah, because
Mhm.
that's what this kind of emphasized, right? Some of the
Mhm.
disparities there.
Mhm.
Yeah, it's
Yes,
really
yes.
important.
All of the social determinants of health have political roots, right?
Right.
So that's why we are very intentional about the policy and advocacy training to increase civic engagement and get folks the training they need to be able to speak with policymakers and decision makers. So yes, thank you, Janice. And it was nice to meet you at the conference last week.
Yeah, thank you. It was. I just want to say too that so I am assuming kind of that perhaps in some of the states where I don't want to sound political, but where they don't have as extensive as opportunities like doulas and whatever, then perhaps you see more disparities in those in those states where they have stricter laws or whatever, not as
Yes.
open. Yeah.
Yes, and they're not reimbursed,
Right.
which is the primary barrier. But yes, all women, but especially Black women, need multiple layers of advocacy, and doulas are worth their weight in salt. You know, doulas will shift the game. So I'm hoping that in the future they will that payers will reimburse for their services, and that they're more widely used.
Yeah, I agree. In Washington State, we did pass a bill and other states have. So anyway, keep up your good work, Aisha. I appreciate it. It was nice to meet you too, and take care. Thank you.
Thank you.
This is Emma, and I don't know, Acha, do you know if this group is aware of the work we've been trying to get maternal health data standardized so it can be shared at the point of care for
Yeah,
care quality?
I don't think they are. I think, well, Sarah mentioned it at the top of the meeting. But we are working with IHE and Patient Care Coordination Committee. I might have those acronyms wrong. To request pregnancy status as its own data class, so that there are common maternal health data elements and across a variety of care settings, because I can tell you, working in different care settings, that often we would not have information, and not having that information causes care delays. And in an obstetric emergency, you don't have that much time. So yes, we've been working very diligently to build a submission to submit to ONC on that front.
Thank you.
Mm-hmm.
Asha, I think we have one more question from Susan regarding whether you're engaged with the longitudinal maternal and health information research IG.
I am not, but I would love to be, Susan. Yes, I would love to be involved in that effort. I have heard about it, but I'm not engaged with that effort right now. It's just with IHE and PCC. But yes, if you have any connections, Susan, and I would love to be engaged in that effort as well.
Wonderful. Okay, I think we're ready to pivot. I apologize for the early pivot. It's just the hazard of getting really emotional as my brain doesn't really click in very well.
Hey, Sarah, I'm sorry to keep interrupting you. I'm on mute.
Yeah.
Anyway, I was just trying to add that that's the point of the work that we're trying to do in IT about collecting the data upstream at the point of care in order for research to be supported. So the research can have that data to be able to do the research stuff.
Yes.
Yes. Yeah.
Yeah. Research, quality measures, care coordination, care provision, it will enable all of that for sure.
Yeah. Yes.
And we're grateful because there's such I use this word, sisterhood among all these different groups, right? So the synergy between IHE and the multiple chronic condition care plan work and Gravity is noted, right? So all of these things, we talk about the Venn diagram of needs, right? And I'm really grateful for us all collaborating, many of the same bodies, right? Moving in between the different projects to make sure that we're all working together and to get this right. Okay, I'm going to try to put the IHE link into the chat while we pivot to policy. Are we ready to do that? Okay.
So
Mark.
next slide, please. And the next slide. Thank you so much, Asha, for all that you do, which includes helping me with something that I'm going to be covering in the policy update that goes back to all the wonderful work you're doing on Black maternal health. So we're going to do a little bit of a recap on US CDI version 2 in order to cover some breaking news for draft version 3. Next slide. So this is just a quick graphic that illustrates what Gravity has done so far. These are the standards that Gravity got into version 2, organized around the activities in the second column, all of the 14 domains in the third column, and the value sets in the fourth column for the clinical care FHIR IG. But this is an annual process. Next slide. So in January of 2022, ONC released a draft version 3. I've highlighted the Gravity projects for data elements as ONC organized them, the assessments, the goals, problems and health concerns and interventions. And then you see a range of other data classes and data elements around that. Next slide. These are the new ones that ONC proposes to add. It's not final yet, but health insurance information, health status. I'm going to have a little bit to say about that one. You'll see pregnancy status is right in there. Labs, patient demographics, and procedures. You'll see from the scale at the bottom, ONC and others are paying attention to whether data elements have help improve health equity, whether they help improve care for underserved communities, and they're noting that explicitly. Next slide. So here's the breaking news. Yesterday, I sit on the Interoperability Standards work group, and we made some substantial recommendations to improve what ONC had released for draft version 3. And the Health IT Advisory Committee voted unanimously to forward all of those to the National Coordinator for consideration and hopefully integration. Today, I just want to highlight 4 of them: gender identity, disability status, pregnancy status, patient-generated health data. And since we just had such a fabulous presentation from Asha, and she so kindly helped me with my work on the Interoperability Standards work group, I'm going to start with pregnancy status first. When I, as a member of the work group, looked at this, I was astonished to find that there were only 3 values for pregnancy status: yes, no, and unknown. And clearly that's inadequate. We learned that this was because the data element had been added at the time of Zika, and I guess either policymakers or doctors or some group thought at the time that the only thing they really needed to know was yes, no, or unknown. And indeed, that was important information to be able to have, and people weren't able to get it. So grateful that at least those were added, but we all know that so much more is needed, and there wasn't anything developed. Normally, if there's nothing developed, you can't get it added into US CDI. It has to be submitted and vetted first. But I know from my work on shared care planning that knowing the intent to become pregnant is critical because of things like medications, prescriptions that might affect fertility. So we recommended, and this is now going to the national coordinator, that a fourth value for intent to become pregnant should be added now to US CDI version 3. And we also flagged, and this was with Asha's great help, that there are many other things that need consideration. So we said that ONC must be working with stakeholders on this in preparation for US CDI version 4. And we identified preconception, prenatal care, pregnancy loss, postpartum period, and interpregnancy period. So this will be a chance, hopefully, to begin to catch up and integrate the kind of critical information that Asha's use cases highlight for Black maternal care and indeed maternal care across all communities. Just one example. Next slide. Oh, excuse me, no, just stay where you are. So second example, gender identity. We had a great presentation from the Gender Harmony Project working with the community around the LGBTQ AI plus community around how better to represent sex and gender diversity in support of improved care and outcomes for gender marginalized people. Fabulous presentation. We recommended, and again, this is a part of the unanimous the vote from the HITAC, that those all 5 of the data elements the Gender Harmony Project put forward be integrated into US CDI version 3. So that's gender identity and sex for clinical use, recorded sex or gender, name to use, and pronouns. And one of the things that we added that is sort of something that comes from the Gravity Project is our increased focus on capturing the source and method of collecting values. It was clear in our discussions that gender identity should be self-reported, and thus, in order to make sure that it's self-reported, that we should be able to capture the source of the value and the method of collecting the value. This builds on work that the Gravity Project has started doing around race and ethnicity in the FIRE IG, but also that we realize this carries over to other data elements as well. So the gender identity value set is in the recommendation as well. Thirdly, disability status, functional status, and cognitive status. Another great presentation from experts in the community about what needed to be in. They highlighted the 6 validated questions from the American Community Survey, which is used for the census, and the 7th question on communication that the Washington group has developed. These are self-reported. So we recommended that those 7 questions be used for disability status. That's a part of the recommendation. A range of suggested value sets for functional status and cognitive status, and also trying to move the ball, keep the momentum, listening for ONC work to be done in getting ready to develop a draft of US CDI version 4 to work around other kinds of statuses, things like autism or social disability, and the caregiver's disability status. Lastly, the 4th item just to highlight is patient-generated health data. We've all known that this is critical. It's been critical for a long time. COVID-19 just illustrates how much the individual and the family caregiver have access to data that is needed for better care, but we're not getting it into the system. So the body of work we did, we recommended adding the author data element to capture that the individual is the source of the information, which is especially important for patient-generated health data and patient-reported outcomes. And we lifted up 5 new data elements that are typically patient-reported or patient-generated health data. And top of the list, family health history. the thing that everybody asks about when you sign up for a new doctor. It's now going to, it's recommended to become a part of USCDI version 3. So next slide, please. So this sort of just illustrates what Asha's use cases were describing. Yes, you have those 4 gravity data elements, but all of those other data elements become critical for the successful use cases that we all need. When we can add those in with the Gravity Project's data elements, that's what it takes to really help us target and improve care and improve health equity. So, breaking news unanimously forwarded to the National Coordinator yesterday. And again, thank you so much, Asha, for your help on the pregnancy status data element. Any questions?
So Mark, there's there's the Homali.
So Homali, I will drop them in the chat when we're finished with my section while Greg's doing the technology. So I have them and I can put them in there. And the next one, that is an interesting question about breast milk, and I don't know. That's certainly not in right now within the element for pregnancy status. Sarah, I don't know if that has been integrated at all with food insecurity work. I'm not aware of it, but you would know far more than I would.
We did talk about it, luckily, because of our SMEs at the time were the A&D. So yes, but I do want to recognize that I think that this is I don't know if we've touched upon it enough. And Denise, I just want to thank you as always for being so insightful. So I want to I'll do an audit and then come back.
So I think that's it for me, Sarah. Thanks so much.
Mark, thank you so much for this work. It's pretty amazing to think about what's currently represented and heading off for finalization and then the work to be done. It's incredibly exciting. So thank you so much for your work there and for your collaboration and integration with our work here. Okay, Greg, the 8-minute update.
Yep, you'll have to excuse me. I'm traveling right now, so I'm just pulling over to the side of the road for a second. But if you could go to the next slide.
Yep. Do you want me to present for you, Greg?
If you don't mind, that would be wonderful.
No, I don't mind at all. I'm a family practice provider, and I would love to have you not park and drive. I'm good.
Just a comment about the Connectathon registration. There's another slide a little further down the deck just showing how few participants that are currently registered. So please encourage everybody to participate in the Connectathon because we need people to come and test.
Yes, I will happily do that. So I'm gonna I can definitely reinforce that. So the tech update, as you all can see, focuses mostly on trying to get folks to attend the May 2nd through 4th Connectathon. There is a cost because of an HL7 Connectathon. I do want to relay that, of course, we do have that upcoming Connectathon with the CMS Connectathon, which is free. But we really do need actors. This is where we test our hypotheses. So please do come. Apparently there's another slide. We do want to state also that we are doing ongoing ballot reconciliation. The technical working group meets every Wednesday in those SDOH working group. And you can find that on the HL7 calendar. And we hope that you join the group there. That's when the technical details are worked through within the IG. Next slide, please. And then that's the same thing. So that's joining that Wednesday meeting. And that's where they're doing the ballot reconciliation now. And next slide. Oh, and then I think maybe that's it. So next slide. Okay, so I don't know if that was the slide Greg was talking about, but I'm going to give.
No, I'm sorry, Sarah. I was thinking about the EC deck. had a different
Oh,
page
yes,
there.
okay.
So
Okay.
just a bit of confusion on my part.
There's many decks today, many meetings. Thank you, Mark, for those are the ACS questions. We just want to make sure that anyone can join the Connectathon. It's really, really important. Again, if you have a cost concern, there is that open CMS free Connectathon coming up later in spring. Next slide, please. In general, we've talked about the review work to do for terminology. The review work is to review the master for health literacy and ask yourself these following questions. Are there things missing? Are things extraneous that need to be removed? And are things that need to be refined because they're not correct? We heard a few comments specifically regarding elements within our goal statements that I think we already have some work to do there. So thank you all for that, and do try to submit. Oh, and then I believe it was Teresa who had a missing element, a missing concept. I'm trying to remember where it was. I think it was within either interventions or goals or diagnoses. So submit those comments to gravityproject@emiadvisors.net. And then review, and then try to keep on submitting elements to regarding health literacy, regarding medical cost burden and health insurance coverage status. And please, please do sign up for the Connectathon if you are able, so that we can test some of the hypotheses and functions of the IG. Next slide, please. Thank you so much, friends. And I want to give a specific shout back to my dear colleague, Asha Manuel. Thank you for bringing your wisdom regarding Black Maternal Health Week to the collective and kind of grounding us this afternoon. And I hope you all have a lovely Thursday evening. Thank you so.
Thanks, Sarah.
Thank you. Bye.